Aortic Emergencies is it's a big talk. Let me talk about deny first. Dr. DeBakey had an operation for acute proximal aortic dissection 6 weeks after it happened, and he was 97 years old, went on to live within 3 months of being 100, and although he had had some reservations about it, he was grateful that they ultimately decided to operate on him. So don't deny. These are some possible disclosures. I'm not going to bore you with a bunch of curves, Kaplan-Meier curves, tables, multivariable analysis, multi-institutional studies, and guidelines and things. A lot of the business of taking care of aortic emergencies is really common sense, having all that knowledge in the background, but working with your colleagues and people that work with you and really putting it all together and managing these things in a common sense fashion. Most of the aortic emergencies are really aortic dissection, but also there's a fair percentage of intramural hematoma where there's no entry site identified, or a penetrating ulcer which is localized but bulges out. There's about 10 cases per 100,000 in elderly population, about 20,000 cases a year in the United States. You're all familiar with the DeBakey and the Stanford classification. He had more of a DeBakey type 2. We're still trying to find out what happened to that resident that told him he had a Stanford type A dissection. But so anyway, you're familiar with these various classifications. I think it's important to know that the Europeans have expanded on this recently. It have added a couple of additional important features which they feel implicates how you actually manage these patients. One of them is where the entry tear is, E0 to E3, depending upon where in the aorta the entry tear is. And then, although I'm not crazy about the way they got this lined up, but there's also some various perfusion beds where there's malperfusion. Coronary is M1, supraaortic is M2, and spinal, visceral, and renal and iliac are M3. So they've added these just recently, which is important. The surgical mortality for proximal dissection is a little under 20%. This is from 2024. When you go back to the first IRAD report in 2000, it was almost twice this number. So a lot of progress has been made. When you do an open operation on distal aortic dissection, the risk of open repair is quite high. Surgical mortality still runs in the IRAD database around 30, a little over 30%. So it's one of the reasons that we try to treat distal aortic dissection without an open operation if at all possible. Some of the other things that we end up with emergencies is when we do a TVAR, have a retrograde type A dissection, which generally is a surgical emergency and also has a rather high mortality rate. Then there's the traumatic tear, which by all indications has been successfully delegated to the TVAR for treatment for traumatic tears, most of these automobile accidents, et cetera. The real bugaboo in these problems, particularly proximal aortic dissection, and well as distal, is the malperfusion problems. In A, pericardial effusion can go to tamponade. B, coronary artery malperfusion, aortic valvular insufficiency by losing the supporting mechanism of the valve, branch vessels to the head, kidneys, and iliac arteries can all create malperfusion problems. The initial treatment, real quickly, is cut down on the aortic wall stress, bring the blood pressure down, treat with beta blockers, and add vasodilators after beta blockade if necessary. Again, malperfusion is extremely important. It can be dynamic so that the flap with the cardiac cycle can move back and forth and cause obstruction, or it can be static where the dissection usually extends out into the branch vessel and creates an occlusion which, even with the flap moving back and forth, is not relieved. Pain control is extremely important, and occasionally patients will have shock and rupture. Occasionally, you need permissive hypotension so that the whatever bleeding is going on can be reduced temporarily till you can get things under control. Type A is in the surgical emergency and bring to the operating room now. Type B, there's uncomplicated and complicated. These are the ones beyond the left subclavian by and large. Uncomplicated is generally medical management. It is very, very successful. Complicated, by and large, has moved towards TEVAR, and I'm not going to go into all of the trials on that, but I will say this, that one of the ways that we move from uncomplicated, declare it complicated, and then treat it with TEVAR are these high-risk features, which include pain, refractory hypertension, pleural effusion. Pretty much all of them have that. They're not very distinguishing. Radiographic-only malperfusion, which is not clinically significant most of the time. Readmission at the initial hospitalization, you can't tell whether they're going to be readmitted. Anyway, these high-risk features, although we use these, in actual fact, there's very, very little data to back any of these up. This is very kind of 2A sort of data, but until we have some prospective randomized trials, and there's several underway, we don't have really a good answer to that. So this is a type A aortic dissection. That's what it looks like. We're happy to say that at Methodist Hospital, Dr. George Morris in 1963, and a 32-year-old physician carried out the first successful type A dissection repair, and all he did really was divide the aorta, closed off the false lumen proximally and distally, and then reattached it. And I can tell you in the early 1980s, I know for a fact this gentleman was still alive. How do we do it? We put him on pump, we cool him down, we get distal perfusion of the innominate artery, we do an open distal anastomosis under hypothermic circulatory arrest, move the clamp down, reperfuse everything, fix the valve, whatever is necessary. If you need to do a root replacement, you do it. Otherwise, you resuspend the valve and repair the false channel and then complete it with the graft. And that's the routine thing. And that's what's done mostly in the United States. We went through a period of doing this where we would actually do this open distal and then drop a stent graft antegrade into the descending thoracic aorta. And when we had malperfusion, and we actually published a series of cases on this, it improved the malperfusion issues distally, both clinically and radiographically. This is an interesting thing, talking about delay. The Michigan group over the years has been proponents of, if you have malperfusion, treat the malperfusion first and then delay the proximal aortic repair. When people talk about this, they forget that when you have rupture and tamponade, those are not the patients that they're talking about. And it decreases the incidence of aortic rupture from 16% to 14% in the 2 decades that they compared it. Then the 30-day mortality rate after bringing them to the operating room later was under 4%. So if I can do this is a patient that, just a quick case, is a 70-year-old gentleman with chest pain, abdominal pain, showed up a while back, and I hope this plays. You can see here the left carotid is out, the innominate's dissected, the left subclavian is dissected, the true lumen is compressed, dissection goes down towards the root. So this is his abdominal CT scan. They were actually done separately. And what it's going to show is the true lumen is tightly compressed. The celiac and the celiac and the hepatic were different. The SMA, I don't know if you can see here very well, but the SMA was actually occluded. The right renal, you can see here, the right renal artery is not very well perfused. So what do you do about a fellow like this? Well, we decided to take him to the operating room right away. This is basically what he had, kind of a typical type aortic dissection with multiple branch malperfusion problems. So he had in-organ malperfusion with a left carotid, visceral SMA, right renal, left iliac, innominate artery, and left subclavian artery. Multiple territory and is unstable. Took him to the OR, and he was tamponading, so it was kind of an emergency situation. You can see his aorta there, and bloody in the pericardium, and he was actually rupturing, but we got him on pump and cooled him down. And basically, this is the operation that we did. This is called a Zone 2 repair, popularized by the Bavaria group at Penn, and the idea is replace the innominate in the carotid artery, and this particular guy, the carotid artery was a mess, but we're able to clean that up and restore flow there and actually put a stent in it. This valve was okay. And then you can come back, usually later, but not always. If you have malperfusion problems, you have to do it right away. put in, it's the Gore TBE graft, which has a branch into the left subclavian artery. And this is what this looks like, that graft. It's a landing zone between the left carotid and the left subclavian artery for the extension of the stent graft later. So he had a Gore TBE graft, and then he had a left subclavian stent, stabilized. It was extended with a Cook TVAR, and then for malperfusion issues was extended with an open Cook dissection, open web graft. And when we studied after that his SMA and visceral vessels, we found that they were open. Here's the arch. Subclavian's open, the left carotid, the innominate. And if I can go back one, you can see here now that his celiac SMA, both renal arteries are open, particularly the selective shot of the SMA. And then his iliac artery on the left side was also involved, but it's also open with a perfusion. He did lose some bowel. So the treatment doesn't end in the ICU. You've got to maintain arterial monitoring and serial imaging. Generally, we'll get a scan before they leave the hospital, then in 3 months, 6 months, and then yearly, lifelong blood pressure control, avoid heavy lifting. And fortunately, we don't have to ask too many people to stop smoking anymore, but it still occurs. So that's just a quick review, just for, I don't have, not a lot of time, but thank you very much.